Great. Thank you, Terry, and thank you to the National Academy for this opportunity to speak about defining quality, which has been a passion of mine for many years. Thanks also for the fine work that the John A. Hartford Foundation has supported over the years. It really was a pleasure collaborating with you at the Commonwealth Fund on some of those initiatives. And then this report that Dr. Farrell just described is really, I think, a great landmark in thinking about quality, forward thinking about quality, and particularly goals 6 and 7, even though they're later in the report, I think are really critical to making progress, not just for people with dementia, but for others who are aging. So I am the Executive Vice President for Quality Measurement and Research at Ncqa. Ncqa has a 30-year history of defining and developing quality measures. It has a set of different roles, actually, in quality. One of its primary missions is to accredit health plans and home and community-based organizations. There are also accreditation programs there, as well as recognition programs for patient-centered medical homes and for care of people with diabetes. And we have programs that plans can use for distinction in long-term services and supports. So there are standards for health plans that they can meet. If they can meet them, they can receive a distinction. And then fundamentally, at sort of the heart of this is the HEDIS performance measurement system, which I had a hand in developing and somewhat overseeing over many years, even prior to coming to Ncqa. And that HEDIS performance measurement system is developed primarily for health plans, but it's actually been, the measures have been repurposed for all sorts of conditions and topics in healthcare. And so they're widely used for diabetes, for the cardiovascular disease, and for medication management and other topics, which we maybe can get into if people have specific questions. I'm also here today as the son of a person with a relatively new diagnosis of dementia. And it's actually been incredibly informative to me to have that experience, as I know others here have already talked about. My stepmother was widowed in 2019, just before the pandemic, and just after she had moved with my father into an independent living apartment connected to a nursing facility. I don't think we realized at the time what a lucky decision that was. This nursing facility in rural central Pennsylvania stands on the site of a cornfield where we used to play when I was a child. And it includes personal care, rehabilitation care, and a memory unit, interestingly, which I didn't really think about at the time. As the pandemic wore on in 2021, my stepmother was finding it increasingly difficult to participate in Zoom calls. She was previously talkative, but when we finally were allowed to visit in August, she had become meek and somewhat passive, even though she had several friends on her hallway. We had hoped that the setbacks that we were seeing were actually just pandemic isolation, and that as she socialized more and the pandemic resolved, which we're still waiting for, that would improve. Unfortunately, our hopes were dashed. Residents and staff were noticing over the subsequent months that she was becoming more withdrawn, more frail. She was repeating herself. And we requested physical therapy and a visiting nurse to help with medications, but in the end she fainted while visiting a neighbor, was found to have low blood pressure, was transferred to the personal care unit where she could be monitored a little more closely than in the independent living wing. And at that point, we really started on a journey of several months of sort of her becoming increasingly frustrated because she was not in her apartment, her becoming agitated, which led to psychiatric evaluation and the prescription of medications, which ultimately led to a low sodium, to a very acute delirium, hospitalization, and but remarkably, she never received a full neurologic evaluation. She was actually discharged back from the hospital to the rehab facility, part of the facility, with ongoing delirium. I actually was interacting with her quite frequently on the phone, and I was warning the staff that she was not really back to her baseline. And then once she got back to the facility, again, this is actually an excellent facility, believe it or not, I have to say. But they then began prescribing benzodiazepine, which actually increased her agitation, made her combative verbally and physically, and ended up back in the hospital a week later with that problem. It took finally some evaluation, but again, not a neurologic evaluation, and they discontinued the medication. She actually resolved. Probably the most shocking thing, though, was when I was visiting a couple of weeks later in the rehab unit, and the nurse, one of the nurses came to me and said, "She seems a little agitated. We're thinking we should start her on Lexapro again." Not again. They were unaware that this had happened, even though it had caused this dramatic set of issues. So throughout those months, her short-term memory began to get worse. The delirium cleared, but the memory problems are clearly worse. And she did finally receive a neurologic evaluation, and I had to call several times to try to get the results of that evaluation. So I'm a primary care physician. I don't think I said that at the beginning. I had seen this pattern several times in my own practice, but to experience it from the caregiver side has been really eye-opening. So I want to say this is a best case. This is a really great facility in many ways. I didn't actually look up the nursing home compare data until I was invited to give this talk, because there really aren't, to my mind, there weren't a lot of other options. We weren't actually making a decision at that point. But I did find that it's a 4-star quality measures facility and 3 stars on the other staffing and investigation or inspection. A couple of points that I think this illustrates. One is about the early detection issue. It's really difficult to recognize memory loss early. We did hear earlier about the loss of insight and how that becomes difficult. One of the consequences of failure to detect this early is that staff, even in a facility that's pretty aware of this problem, often frames bad behavior as willing bad behavior rather than as a manifestation of the disease. I was also struck that even with this excellent staff, that my observations were often disregarded. Sort of, I'm not living in the area, even if I have known her for a long time and can discern a lot over the phone, and actually had a professional background as well. It didn't seem to matter in terms of some of the advice that I was offering or observations. The second is access, and I was really pleased to hear about the rural initiative, because access in rural areas is really, it's at crisis levels, I think, and neuropsychiatric evaluation, even in a place like Boston where I practiced for years, was difficult to arrange. And then medications and medication management are so crucially, in need of adaptation when someone has such a diagnosis. So I do want to talk in particular about the problem that I think was highlighted more than anything else here, which is the problem of coordination. And I'm going to see if I can get that. There we go. I loved this conceptual model from the nursing home report. It actually really is well structured. It identifies the key challenges and some of the needs in a nursing home facility. But I think it's important to point out that it's an organization-specific quality model. And we focus on organizations because CMS regulates organizations. Organizations have financial and work staff and other management capabilities. But organization-specific quality models don't really get to the heart. They will help in terms of organizations, but don't get to the heart of many of the quality problems for persons with dementia or other chronic diseases for that matter. Because from the patient's perspective, the root of the quality gaps is really the poor coordination among our organizations and clinicians. The difficulty, even for me, to get through to her primary care physician early in the course when things were not going well, to communicate with the specialists to the extent I could even find specialists. I never have figured out, I still am trying to figure out her health insurance and what it covers and may not cover. But from the patient beneficiary, if we really think about the model stepping back, there's an ecosystem here of insurance payment, care delivery organizations, and the public and social health and social service agencies, community-based organizations, all of which are interacting with patients and beneficiaries. And the caregivers, which I think are, as I've highlighted, are really so crucial, and others have highlighted that as well. This really put me in mind of the patient-centered medical home model. So if we improve nursing home quality, that would be fantastic. We've actually made great strides in improving primary care team work in using the patient-centered medical home model and the payment models that CMS has created. And I like this figure from Wagner et al. From 2012, which sort of points out that there's a foundational sort of stepwise need to develop capabilities, starting with laying a foundation of QI strategy and engaged leadership, moving up the chain here. I won't go through this in detail, but the very top layer is actually where care coordination happens. You really need all of the other fundamental pieces in place to be able to perform on reducing barriers to care through enhanced access and care coordination. I think nursing homes may face a somewhat similar journey, especially for persons with dementia. So I'm going to, there's no timer, so I'm probably over. Okay, thank you. But I do want to point to what I think are some of the real quality accountability imperatives for people living with dementia. And I've kind of grouped them this way. I actually think this issue of situational awareness is something we don't emphasize enough in our quality measurement systems. And the reason we don't is because for years we've sort of relied on claims data. And claims data lag. They lag 3 months, they lag 6 months. Sometimes you can't date stamp or time stamp anything coming from claims effectively. So it's very hard to understand the sequence of events that occur in the journey of any one patient or set of caregivers. To get true situational awareness really requires a capability to exchange data fairly quickly and to be able to identify problems and share that information with other participants in the system. And I think at the top of that situational awareness has to be caregiver support for people with dementia and people with even early symptoms and signs. Actually, the transitions are incredibly difficult to manage. And as I've seen now, transitioning all the way to a memory unit within a matter of a space of 8 months, this is not an easy trick to pull off. There are multiple transitions and there's multiple people who need to be coordinated. Whether services are accessible or not is really also crucial. And then this issue of safety is so critical. The medication, there were avoidable hospitalizations, at least two avoidable hospitalizations in care of my stepmother. But on the other hand, there were some interesting challenges around fall prevention that actually restricted her and frustrated her in ways that were probably unnecessary. So she literally told me the staff would yell at her when she got out of the chair because they were so worried about her falling. So we have to be really mindful that our quality metrics don't create incentives that lead staff to act in ways that are counterproductive for people with dementia who may not have the insight, need to take a few more risks, or we may need to think of more innovations to sort of make people safe in that environment. And then I want to just also think the focus on intermediate health outcomes, which we tend to want to sort of get to end state health outcomes, but functional status, cognitive ability, being able in real time to monitor behavioral cognitive issues, I think is something our systems don't do well right now. I've written before about goals and goal attainment as a potential metric system for quality measurement. We should probably be thinking less about clinical measures based on clinical guidelines and more about goal-directed outcomes and goal-directed measurement. And then the effectiveness of communication between caregivers and team. I do think the CAPS surveys can help. I think we're going to need new administration approaches because our paper-based surveys are not timely enough. And then coordination of care I've already somewhat talked about, but the effective information sharing and being able to measure information sharing is something other industries do remarkably well with their digital systems. We would not, all of what I'm describing here requires a data infrastructure that we currently just don't have in a meaningful way. We're operating a national air transportation system without an air traffic control function. We just don't think about the design of our systems as sort of in the way that other industries think about the use of data to coordinate logistics. I was struck in sort of closing up my mother's apartment that we were getting telemarketer calls nonstop. And I realized, you know, the telemarketers actually know that she's vulnerable. They have identified her. What would it take for our healthcare system to be equally sensitive to predicting the needs and wants of people who are developing dementia? I think they actually probably could pull this trick off better than anything we're doing now. It just struck me that she was particularly vulnerable on that front, and they knew something that we needed to leverage. So I just want to finish now. Ncqa is, oops, let me see if I can get that to go, is really focused now on the expanded use of electronic data. There's some good tailwinds in that we can operate on. The Cures Act and the regulations around data exchange interoperability are really setting, I think, will set the foundation for a sort of data exchange capability that could support some of what I've been describing. The broadband investments of $65 billion that somehow slipped under the radar, nobody seems to be aware of that, is now being spent in states. States have the opportunity to tie that broadband funding to issues like nursing homes and community-based organizations. And then I think at the end, the message I would like to leave folks with here is I think there's a temptation, as there has been for 20 years, to say, well, if we change the payment system and the payment incentives, that will lead to the changes we want to see in the system. And I think that absolutely fundamentally necessary to change those payment incentives, but those changes are not going to be sufficient to drive the kind of digital infrastructure reengineering and systems reengineering and organizational improvement that we're really hoping to see. So I would remind folks to think about what else might need to change in the infrastructure environment and what other investments might be needed to maximize the return on investment for these payment model changes. So I'll stop there. Sorry if I went over.
You're fine, Eric. Thank you. It's a heart-wrenching story. And you just gave 2 talks, one for 4Ms and one for elder abuse and neglect screening. So thank you, and we look forward to continuing to hear. Yeah.